Hello, good morning to all. I am Dr. SARADA, Professor in the Department of Anaesthesia, Mallarity Medical College for Women. Today I am going to take lecture on general anesthesia. At the end of the session, the learner should be able to describe steps of general anesthesia, mechanism of action of induction agents and inhalational agents. I am going to present stages of anesthesia, mechanism of general anesthesia, pharmacokinetics, uptake and distribution of inhalational anesthetics, and difference between local and general anesthesia. Definition of general anesthesia. General anesthesia is medically induced loss of consciousness with concurrent loss of protective reflexes due to anesthetic agents. Various medications administered to induce unconsciousness, amnesia, analgesia, skeletal muscle relaxation, and the loss of autonomic system reflexes. General anesthesia consists of unconsciousness, analgesia, and amnesia. A variety of drugs are given to the patient that have different effects with the overall aim of ensuring unconsciousness, amnesia, and analgesia. What are general anesthetics? A drug that brings about a reversible loss of consciousness, generally administered by a qualified anesthesiologist in order to induce or maintain general anesthesia to facilitate surgery. What are the stages of general anesthesia? These stages of general anesthesia cannot be seen with all anesthetic agents, mainly seen with ether, but that is not, nowadays it is outdated, not using. But at least some of the stages we can see with anesthetic agents. Stage 1 is disorientation and altered consciousness. Stage 2 is excitatory stage, delirium, uncontrolled movement, irregular breathing. Goal is to move through this stage as rapidly as possible. Stage 3 is surgical anesthesia and return of regular respiration. It is having 4 planes. Plane 1 is light anesthesia. Plane 2, loss of blink reflex, regular respiration. Surgical procedures can be performed at this stage. In plane 3 is deep anesthesia, shallow breathing, assisted ventilation is needed, and level of anesthesia for painful surgeries. Plane 4 is diaphragmatic respiration only, assisted ventilation is required, and cardiovascular impairment will be there. Stage 4 is too deep, essentially an overdose, and represents anesthetic crisis. This is the stage between respiratory arrest and death due to circulatory collapse. These are the stages of anesthesia: diaphragmatic respiration and intercostal respiration, seen with stage 1, stage 2, plane 1 and plane 2, and plane 3. And the ocular movements also, some voluntary control and pupillary dilatation, and eye reflexes can be seen. Pupillary light reflex up to plane 3. Pharyngeal and laryngeal reflexes and glottic reflexes, and secretion of tears, muscular tone, and respiratory response to skin incision. So in plane 3 up to plane 2 and plane 3, we can ask the surgeon to start the case, start the surgery. So plane 2 and between plane 2 and plane 3. And what is the pathway for general anesthetics? There is an inspired gas mixture goes through the alveoli and then through the arterial blood and reaches to some other tissues, and some amount may metabolize and some amount may reach the brain. So from the brain, and again it reaches through the venous blood to other tissues, and it comes to the alveoli and then to the inspired gas mixture. This is the pathway for general anesthetics. Anesthetics are divided into two classes: inhalational anesthetics and intravenous anesthetics. Inhalational are mainly gases or vapors, usually they are hallucinated. Intravenous are by injections. Anesthetics are induction agents. Inhalational anesthetics, nitrous oxide and halogenated anesthetics. So in halogenated, halothane, isoflurane, sevoflurane and enflurane. Mechanism of action of inhalational agents: interaction with protein receptors or volatile anesthetics increases the GABA and glycine inhibitory neurotransmitters. So halothane, enflurane, isoflurane, sevoflurane and desflurane mainly acts on the GABA receptors and the desflurane are NMDA receptors, whereas isoflurane has 2,4 domain potassium channels. What is minimum alveolar concentration? A measure of potency of inhaled anesthetics. Minimum alveolar concentration is the concentration necessary to prevent responding in 50% of the population. Pharmacokinetics of inhaled anesthetics. The amount that reaches the brain indicated by oil-gas ratio, that is lipid solubility. Solubility of gas into blood. Lower the blood gas ratio, the more anesthetics will arrive at the brain. So rate of entry into the brain by influence of blood lipid solubility. So this is nitrous oxide and halothane. And general actions of inhaled anesthetics. Respiration. There is a depressed respiration and response to carbon dioxide. Inhaled anesthetics depresses the renal blood flow and urine output. Muscle high enough concentrations will relax the skeletal muscle also. And cardiovascular system, there is a generalized reduction in arterial pressure and peripheral vascular resistance. Isoflurane maintains cardiac output and coronary function better than other agents. And central nervous system, increased cerebral blood flow and decreased cerebral metabolism. Nitrous oxide. It is widely used. Nitrous oxide, potent analgesic, produces light anesthesia, do not depress the respiration or vasomotor center. It is used as an adjunct to supplement other inhalational agents. Halothane. It is non-flammable. 20% is metabolized by P450. Induction of hepatic microsomal enzymes and myocardial depressant action on SA node and sensitization of myocardium to catecholamines. It may cause arrhythmias. Halothane may cause transient hepatic damage and it may cause liver necrosis in repeated exposure, and immunosensitization will be there. What is malignant hyperthermia? Malignant hyperthermia is a pharmacogenetic hypermetabolic state of skeletal muscle induced in susceptible individuals by inhalational anesthetics or succinylcholine and maybe by stress or exercise. There is a genetic susceptibility of calcium channel defect or anodine receptors. There is excess calcium ion leads to excessive ATP breakdown and depletion. Signs of malignant hyperthermia. There is a tachycardia, tachypnea, metabolic acidosis, hyperthermia, muscle rigidity, sweating and arrhythmias. May be fatal. It will be treated with dantrolene. Enflurane. Rapid and smooth induction agent and maintenance 2 to 10% metabolized in the liver, introduced as a replacement for halothane. Isoflurane is smooth and rapid induction agent and smooth recovery and very little metabolism by 0.2% only. No reports of hepatotoxicity or nephrotoxicity with the with isoflurane. So most widely used nowadays. So intravenous induction agents. Commonly used intravenous induction agents are propofol, thiopental sodium, ketamine, and etomidate. Etomidate, propofol, and other barbiturates mainly acts on GABA receptors, whereas ketamine, nitrous oxide, and cyclopropane acts on NMDA receptors. Intravenous anesthetics. Most exert their action by potentiating GABA receptors. They may be similar to those of volatile anesthetics but act at different sites on receptors. Organ effects. Most decrease cerebral metabolism and intracranial pressure. Mostly cause respiratory depression. Most of the intravenous anesthetics cause respiratory depression. It may cause apnea after induction of anesthesia. Barbiturates, benzodiazepines, and propofol, they cause cardiovascular depression. Thiopental sodium is a rapid onset within 20 seconds and it is a short acting. And thiopental sodium side effects are hypotension, apnea, and airway obstruction. Propofol is a short-acting agent used for the induction and maintenance of general anesthesia and sedation. Onset is within 1 minute of injection. It is smooth induction agent and smooth recovery. It is highly protein bound in vivo and it is metabolized by conjugation in the liver. Side effects are pain on injection, hypotension, transient apnea following induction. Ketamine. It is a NMDA receptor antagonist, usually stimulates rather than depresses the circulatory system. Ketamine is an analgesic, dissociative anesthesia, cataleptic appearance, eyes open, reflexes intact, purposeless but coordinated movements. Ketamine stimulates the sympathetic nervous system. Psychomimetic emergence reactions may be seen with ketamine. There is maybe vivid dreaming, extracorporeal experience, that is floating out of body, misperceptions and misinterpretations and illusions. May be associated with euphoria, excitement, confusion and fear. To prevent these hallucinations and all, we are using along with ketamine, some benzodiazepines and anticholinergics to prevent secretions. General anesthesia is divided into induction and maintenance. Induction by intravenous anesthetic agents or by maintenance with inhalation agents. Intravenous, faster onset, avoiding the excitatory phase of anesthesia. Inhalation is used where IV access is difficult, where anticipated difficult intubation, and especially in children. Patient preference is children. In order to prolong anesthesia for the required duration, breathe to a carefully controlled mixture of oxygen, nitrous oxide, and volatile anesthetic agents. Transferred to the patient's brain via the lungs and the bloodstream, and the patient remains unconscious. Inhaled agents are supplemented by intravenous anesthetics such as opioids, usually fentanyl or morphine. What is balanced anesthesia? Use specific drugs for each component. For sensory, you can use nitrous oxide, opioids, ketamine for analgesia. Whereas for cognitive, produce amnesia and preferably unconsciousness. Inhaled agent, IV hypnotic propofol, midazolam, diazepam and thiopentol for motor muscle relaxants. Simple combinations like morphine, propofol, nitrous oxide, sevoflurane and relaxant of choice. According to the surgery, we have to assess which combination is better for surgery procedures. Other combination is fentanyl, thiopentol sodium, nitrous oxide, halothane and relaxant of choice. Pharmacology. Pharmacokinetics and pharmacodynamics. Pharmacokinetics is what body does to the drug, like absorption of the drug, uptake, distribution, metabolism and excretion. Whereas pharmacodynamics, what drug does to the body, like effect on various organs, systems, etc. Factors controlling the brain levels. Production and delivery of suitable concentration of anesthetic agent for inhalation. Factors affecting the distribution of this agent to the lung. Uptake of the drug by the blood from the lung and delivery from circulation to the brain. Delivery of adequate anesthetic agent depends on the delivered concentration, washing of the circuit. Higher inflow rates required initially to wash in the circuit volume with anesthetic gas mixture. Loss of anesthetic to plastic and soda lime, and there may be a rebreathing. Anesthetic circuits. High flow, low flow and closed circuit anesthesia. High flow is more than 5 liters per minute. There is advantages are increased predictability, disadvantages waste of gases, atmospheric pollution, and it may be costly also, and drying of inspired gases. In low flow means fresh gas flow less than half of the minute volume, that is 3 liters per minute. Closed circuit anesthesia, flow sufficient to replace the gases removed by the patient. What are the advantages and disadvantages of closed circuit anesthesia? Advantages: lower cost, humidification, reduced heat loss and less environment pollution. Whereas disadvantages are lack of control, hypoxic mixture can be delivered, and ratio is governed by the uptake. Delivery and anesthetic gases ratio is governed by uptake. And low flow anesthetic delivery. It mitigates instability of the closed circuit. Constant oxygen and anesthetic levels. Elimination of carbon dioxide and other toxic anesthetic breakdown products. So delivery of anesthetic agent to lung and alveoli. Partial pressure of anesthetic agent in alveoli governs the partial pressure of anesthetic agents in arterial blood, and then in all body tissues, especially brain. So delivery of anesthetic agent to lung and alveoli. Alveolar levels are governed by factors promoting delivery to the lung, inspired concentration of the anesthetic agent and alveolar ventilation. Factors promoting uptake of anesthetic agent by the blood passing through lung. Effect of inspired concentration. So it may cause concentration effect. By increasing the inspired concentration, not only increases the alveolar concentration, but also increases the rate of rise of volatile anesthetic agents in the alveoli. So concentrating effect augmentation by inspired flow. So nitrous oxide in this diagram, nitrous oxide 80% and oxygen 19%. Second gas effect will be there. So nitrous and oxygen 66%. So it is a standard diagram of hypothetic lung used to discuss gas exchange during nitrous oxide uptake, and percentages are of total volume in each rectangle. Augmented inflow effect due to inspiration of additional volume of gas mixture to replace that lost by uptake. Second gas effect. A high concentration of nitrous oxide augments its own uptake and that of concurrently administered volatile anesthetic also. Thus, passive increase in inspired ventilation due to rapid uptake of large volume of nitrous oxide increases the rate of rise of second gas in alveoli regardless of anesthetic agent concentration. This is second gas effect. It is a hypothetical lung used to discuss gas exchange during nitrous oxide uptake. So percentages are of the total volume in each rectangle. This is the second gas effect. 50% of nitrous oxide taken up, and during inspiration containing 80%, nitrous oxide 19%, oxygen and 1% second gas. So what is hyperventilation? Hyperventilation increases the alveolar concentration directly. So decreases the cerebral blood flow and reduces rate of rise of anesthetic agent concentration in the brain. So balance depends upon the solubility of anesthetic agents used. Solubility. It describes how a gas or vapor is distributed between two media at equilibrium. For example, between blood and gas, between tissues and blood, etc. Higher blood gas partition coefficient means more solubility and greater uptake, and vice versa. So higher blood gas partition coefficient, more solubility and greater uptake. So anesthetic agents, blood gas coefficients. Anesthetic agent, desflurane is having 0.45, nitrous oxide 0.47, sevoflurane 0.65, isoflurane 1.4, halothane 2.5 and diethyl ether is 12. So blood gas coefficient is more with the ether and less with 0.4 this desflurane. So higher blood gas partition means more solubility and greater uptake. So uptake and solubility. The more soluble the anesthetic agent is in blood, the faster the drug goes into the body. The more soluble the anesthetic agent in blood, the slower the patient becomes anesthetized. To some degree, this can be compensated for by increasing the inhaled concentration, but there are some limits. Cardiac output. Cardiac output is equal to stroke volume into heart rate. So amount of anesthetic agent in each alveolus is fixed between breaths. Increasing the volume of blood improves the amount of anesthetic agent absorbed, but the concentration of the agent in the blood is lower. Higher the cardiac output creates lower the plasma concentrations. So increased cardiac output slows the rate at which the patient goes to sleep. Low cardiac output states like shock, it increases the alveolar concentration of more soluble agents. So use of less soluble agents like nitrous oxide is preferred. So positive feedback, anesthetic agent increase their own alveolar concentration by depressing the circulation. So lower cardiac output states it increases the alveolar concentration of more soluble agents. and anesthetic agents increases their own alveolar concentration by reducing the circulation. Doubling of both ventilation perfusion should produce no net changes in the concentration of anesthetic agent in alveoli, but an increase in cardiac output decreases the alveolar to venous partial pressure difference, thus reducing the uptake. So net result is increase in the rate of rise in alveolar to inspired oxygen concentrations. This is true for conditions like hyperthermia and thyrotoxicosis, where increased cardiac output is distributed equally to all tissue groups. Children, especially in infants, have greater perfusion of vessel-rich group. So more rapid development of anesthesia in young patients. So ventilation perfusion mismatch increases alveolar end-tidal partial pressure of anesthetic agent, decreases the arterial pressure. There is a relative change, and thus induction of anesthesia depends upon the solubility of the anesthetic agent. In endobronchial intubation, hyperventilation in intubated lung, and there is a shunting in unventilated lung. So more soluble agents like halothane and ether rapidly increase due to hyperventilation, thus compensating for absence of uptake from unventilated lung. This compensatory mechanism is absent with poorly soluble agents. The poorly soluble agents like sevoflurane, desflurane would achieve lower concentration and hence delayed induction than more soluble agents like ether in clinical condition with ventilation perfusion mismatch if compared with normal ventilation perfusion. Alveolar and venous anesthetic agent partial pressure difference is the result of uptake of anesthetic agent by the patient's tissues. This difference remains until the tissues are saturated and at equilibrium, tissue and blood solubility and tissue blood flow. During induction, rapid removal of anesthetic agents by the tissues causing increase in alveolar to venous gradient, leading to maximum anesthetic uptake. With passage of time, there is an increase in tissue concentration, decreases the gradient, thus reducing the uptake. So delivery of anesthetic to tissues. Uptake by the tissues are governed by solubility of the agent in the tissues and tissue blood flow and arterial tissue partial pressure gradient. Tissue blood gas partition coefficient vary less than blood gas partition coefficient. So the rate at which tissue anesthetic partial pressure reaches the arterial level is fairly uniform for all anesthetic agents and depends upon the blood supply to the tissues. So these are the tissue group characteristics. Vessel-rich group, muscle-rich group, fat-rich group and vessel-poor group. So percentage of body mass is 10 where in vessel-rich, whereas in muscle it is 50, in fat it is 20 and vessel-poor is 20. Percent cardiac output, 75% in vessel-rich group, muscle 19, fat it is 6%, vessel-poor it is 0. Perfusion per ml per minute per 100 gram. Vessel-rich group it is 75, muscle-rich group it is 3 and fat it is 3 and vessel-poor it is 0. So vessel-rich group equilibrates within 8 to 10 minutes, whereas muscle group determines most of the tissue uptake after that and require 2 to 4 hours to achieve equilibrium. The fat group has greater affinity for anesthetic agent, which considerably increases the time over which it absorbs anesthetic. Equilibrium is never achieved. Recovery from anesthesia or washout. What are the factors affecting the elimination? Elimination by biotransformation, cytochrome P450 or transcutaneous and visceral loss. It is insignificant. Exhalation is most important. What are the factors speeding the recovery? Identical to those present during induction. There is an increased ventilation, elimination of rebreathing, high fresh gas flows, anesthetic washout from the circuit volume, and there is a decreased solubility and uptake, and high cerebral blood flow and short duration of exposure. So why it is different from induction? During induction, effect of solubility to hinder increase in alveolar concentration can be overcome by increasing inspired concentration. So not so during recovery, as inspiratory concentration cannot be reduced below zero. So tissue partial pressures during recovery are variable, unlike equal tissue partial pressure, which is zero during induction. So elimination of nitrous oxide is so rapid that alveolar oxygen and carbon dioxide are diluted, and maximum during initial 5 to 10 minutes. So oxygenation hampered due to diluted alveolar oxygen tension. So decrease in carbon dioxide leads to decreased respiratory rate and hence ventilation. So diffusion hypoxia. So diffusion hypoxia shows minutes from end of nitrous oxide anesthesia. So what is the comparison between general anesthesia versus local anesthesia? Site of action, general anesthesia and central nervous system, whereas in local anesthesia it is on peripheral nerves. Area of the body involved is whole body in general anesthesia, in restricted area in local anesthesia. Consciousness is lost in general anesthesia, it is unaltered in local anesthesia. Care of vital functions are essential in general anesthesia, also needed in local anesthesia. Poor health patients are risky in general anesthesia, it is safer in local anesthesia. Use in non-cooperative patients possible in general anesthesia, it is not possible in local anesthesia. Major surgery preferred general anesthesia, not preferred local anesthesia. Minor surgery, general anesthesia preferred, not preferred, and whereas local anesthesia it is preferred. Thank you.